Hello, my name is Dr. Ukiri Richard. The podcast on cardiology today continues with the topic progressive shortness of breath. A 65-year-old male patient was admitted for complaints of 2 weeks history of exertional dyspnea. Physical examination revealed a patient with reduced general condition, but there were no cyanosis or icterus. The jugular venous pressure was slightly raised, and the heart rate was 145 per minute, and it was arrhythmic. The respiratory rate was about 18 per minute. Blood pressure was 120 to 85 millimeters of mercury. Oxygen saturation 95%, and in auscultation you could hear a 2/6 systolic murmur over the aortic valve with radiation to the carotid. There were also basal crepitation bilaterally without rhonchi. In the blood gas analysis, you saw an oxygen saturation of 92%, partial oxygen pressure 64, carbon dioxide 30, and pH 7.4. The cardiac marker and D dimer were elevated. The question now is, what possible causes of exertional dyspnea do you have to exclude in this case? Well, exertional dyspnea is actually an indicator of a left heart failure. Let me break down the causes of exertional dyspnea. For cardiac causes, you have acute coronary syndrome or unstable angina pectoris. It could also be stable angina pectoris. It could be heart rhythm disturbances like tachycardic conducted atrial fibrillation. It could also be dilated cardiomyopathy. It could be a hemodynamic relevant valvulopathy. It could be hypertensive derangement or hypertensive heart disease, myocarditis, or pericardial effusion. For the pulmonary causes, you have pulmonary embolism, COPD with exacerbation, or pneumonia. Other causes could be anemia, hyperthyroidism, AV fistula, and sepsis. So what will be the first diagnostic test that you will carry? Well, the first test I will do a 12-channel ECG as well as a chest X-ray. So you did the ECG, and I'll tell you the findings. You saw an irregular broad QROS tachycardia without sinus P wave, which is actually a tachyarrhythmia absoluta, that is an atrial fibrillation with tachycardic conduction, heart rate of 145 per minute, with white QRS complex due to left bundle branch block. In the chest X-ray you did, which was actually done supine, as far as you could judge in the supine position, the heart was not enlarged. The pulmonary vessels were not prominent, in like you would have in congestion. There were no infiltration. The trachea is middle positioned, and the mediastinum was prominent. There was a reduced perfusion in the basal part, which makes you think of an effusion. There was also a light opacity in the left basal region. So what diagnosis are you suspecting now? Or what diagnosis do you think will be likely? Well, based on the findings we have and the result we have, I will suspect a pulmonary embolism because of elevated D dimer. 2, I will think of acute coronary syndrome, which cannot be excluded, especially with a left bundle branch block, because we do not know how long the left bundle branch has existed. And 3, I will also think of heart failure with beginning pulmonary edema due to tachyarrhythmia absoluta from atrial fibrillation. So what diagnostic tests will be very necessary in this case at this step? Well, The leading presenting symptom here is shortness of breath. There is no angina pectoris. So the next diagnostic test I will do is a computer tomography of the thorax with a view of checking for pulmonary embolism. Okay, you did this computer tomography. Let me tell you the result. There were no indication for central or peripheral pulmonary embolism. There was no sign of right heart stress. There were bilateral pleural effusion bilaterally, right more than left, but it's not enough for puncture. And there were also one well circumscribed opacity right on the right part with thickening of the bronchial wall. Differential diagnosis here is an initial bronchopneumonia right-sided or atelectasis. There was no space-occupied lesion or pneumothorax. The heart was enlarged with left ventricular configuration and significant calcification of the aortic valve. The rest of the thoracic aorta just had minimal plaques. Also, you could see some calcification in the LAD and LCX. The other thoracic arteries were okay. My question now is, after you have excluded pulmonary embolism in this patient with elevated cardiac markers, would you like to, and he had heart failure, would you see the indication to do an invasive diagnostic, that is coronary angiography? Of course, the next diagnostic test I will do after pulmonary embolism has been excluded will be the coronary angiography to check for the coronary status. Okay, you did the coronary angiography starting with the level cardiography. You saw the left ventricle was dilated and there was globally reduced function, with left ventricular ejection fraction estimated to be 27% and the end diastolic pressure was 18 millimeters of mercury. There were regional contractility disturbances in anterior and apical region. There were no relevant mitral insufficiency regurgitation, but across the aortic valve there was a pressure gradient of 50 milliliters mercury peak to peak. In the coronary angiography, the distal part of the main stem had a moderate stenosis. In the river, there was a complete occlusion from the middle part. The ROCX had a direct after in the ostium and in the In summary, the invasive diagnostic has shown an ischemic cardiomyopathy as well as a pressure gradient above the aortic valve. The acute cardiac failure or decompensation is most likely due to the atrial fibrillation with tachycardia. So you are thinking of doing an electric cardioversion. Before this, you are expected to do an echocardiography and transesophageal and transthoracic and transesophageal echocardiography. So, in the transthoracic echocardiography, the aortic root was normal, aortic valve had light regurgitation with pressure half time of 335 milliseconds and vena contracta of 6 millimeters. The maximum velocity across the aortic valve was 3.05 meters per second with a maximum pressure gradient of 37 millimeters of mercury and a mean pressure gradient of 22 millimeters of mercury. The right atrium visually judged had normal size. Left atrium was slightly dilated. Right ventricle was normal in size with normal wall thickness. The right ventricular function was minimally reduced. Left ventricle was had normal size. the walls were lightly thickened. There is mild systolic global dysfunction. According to planimetry, the ejection fraction was 32%. In the mitral valve movement were normal. There was significant regurgitation with vena contracta of 8 millimeters. There were no stenosis. Tchaikovsky valve had normal movement. There was mild regurgitation. Maximum pressure gradient from right ventricle over to right atrium was 27 millimeters of mercury. In the transesophageal echocardiography, there were no intracavitary thrombus in the left atrium, left intral appendage, right atrium, right ventricle. Aortic valve was significantly thickened with reduced opening area. Because of the tachycardia, the planimetry of the aortic valve opening was not done. So in summary, we have seen a case of a combined aortic valve disease, that is stenosis and regurgitation, with the suspicion of a possible high grade, that is severe aortic valve stenosis, which on the background of the reduced left ventricular function, the hemodynamic relevance cannot be classified. Actually, is a low gradient aortic stenosis. Presently, the next step should be to recompensate the patient. And from the findings we have, an electric cardioversion can be done with the aim of achieving sinus rhythm. So, tell me now what you know about the problems of left ventricular dysfunctions in aortic stenosis, low gradient aortic stenosis, and atrial fibrillation. Okay, the truth is that the hemodynamic relevant aortic stenosis will cause a concentric left ventricular hypertrophy through increase in wall tension. The reduced compliance of the ventricle and the elevation of the left ventricular end diastolic filling pressure results in a diastolic dysfunction, so that an increase in atrial contraction will be needed to complete the ventricular filling, but without raising of the middle atrial or pulmonary venous pressure. So in cases of atrial fibrillation where there is the absence of the atrial contraction, you could clinically see a sudden worsened clinical state like the one we have now at hand. So that with due course of the sickness, after exhaustion of the compensatory mechanisms, you will see development of chamber dilatation with functions restriction, with reduction of the function. This reduction of function is actually caused by reduced left ventricular contractility or strongly raised afterload. Because of this, the transvalvular gradient, especially in cases of high grade aortic valve stenosis, will be reduced and underestimated or misjudged. So, thank you very much. My next question now: dobutamine stress echocardiography. What is the rationale of the low dose dobutamine stress echocardiography? Well, the low dose dobutamine stimulation stress echocardiography is of help when you are deciding about valvular replacement in patients with reduced left ventricular function, especially when you have to clarify the cause of the function restriction, if it's valve associated or due to the dilated cardiomyopathy. With a dobutamine dose of 20 microgram per kilogram per minute, studies have never shown a complication in patients with aortic stenosis. Under this examination, you watch out for increase in the left ventricular cardiac stroke volume, which is the contractile reserve, as well as the transvalvular pressure gradient. Both will simultaneously be measured. If you notice that when the stroke volume is increased, there is also a raise in the pressure gradient, that is fixed stenosis. That shows that the aortic stenosis is the cause of the dysfunction and it is an operation indication. But on the contrary, if under this examination you saw an increased stroke volume, but there is reduction in the stenosis and the opening and an improvement in the opening surface area of the valve, which is pseudo stenosis, then you do not expect an improvement from an operation. Also, I would like to let you know that apart from the diagnostic importance, this test also helps in risk stratification. Patients that have good contraction reserve, that means elevation of the ejection fraction above 20%, they have very, very low perioperative mortality. They also tend to have an improved pump function post-operatively. When you do not have, or when in the absence of contraction reserve, it is most likely an irreversible myocardial damage that you have, and the perioperative risk is very high. I'll let you know that additionally you could also do a transesophageal echocardiography to do a direct planimetry measurement of the opening surface area of the aortic valve. So you did the dobutamine stress test, and let me tell you what you found. You used 20 microgram per kilogram per minute of the dobutamine. The aortic valve had a high grade stenosis with valve opening surface area that is of 0.7 square centimeter. There was an increase in the Vmax from 3.4 to 4.5 meters per second. The maximum pressure gradient also increased from 47 to 80 millimeters of mercury. The middle pressure gradient also increased from 27 to 44 millimeters of mercury. In the 4-chamber view, under the dobutamine, you saw a normalization of the pump function with only mild hypokinesia in epicoseptal region. So, in summary, from what we have seen, we have seen an elevation of the stenosis grades under stress, with a relevant aortic valve stenosis and left ventricular function restriction. Parallel, we also saw an ischemic cardiomyopathy with a high-grade coronary three-vessel disease. Under the dobutamine stress test, we saw a good contraction reserve